Good afternoon, everyone. At the outset, I would like to thank Dr. Aditya Kelkar for giving me an opportunity to be in this interesting session. Uh, it's on medico-legal aspects of endophthalmitis is the topic given to me. So I'll see what best I can do and how justice I can do to this topic. Thank you, AIOS, for this and organizing a wonderful conference. So we all know that intraocular infection has always brought disrepute to the ophthalmologist, and this problem is not only rampant at the eye camps, but also in the hospitals where you can call 3-star, 5-star, or 7-star also, occurs in the best of the hands. Despite the best possible care, the mishaps cannot be avoided because an error in one link of the entire chain of treatment may sometimes result in a disaster. So a chain is only as strong as its weakest link. But if in the court of law we have a misfortune of infection, then how to save ourselves? So first thing is maintenance of the proper records. Documentation of ocular examination includes pre-post-surgery, recording of the minute details, if require any ultrasounds or ECG if the patient is not fit. Histopathological reports are irrefutable proof of proper diagnosis and treatment and are extremely important for medico-legal aspects. So this was the case. The hospital and the doctor were guilty of deficiency in service as the case records were not produced before the court to refute the allegation of a lack of standard of care. Just because the case papers were not in a proper format, they lost this case. The doctor lost this case. So the machine reports, oxygen cylinders, ECG monitoring, pulse oximeters, anything, whatever we do has to be recorded, and whatever is relevant for that patient has to be done. And a general physician is his records are also extremely important, and all medicines or consumables should be of the standard quality. So let's look into this case, small case. Post-cataract surgery, both the patients develop endophthalmitis. Hospital was negligent as no proper sterilization was done in the OT by XXX hospital. I don't want to name this. This hospital was in Maharashtra. And that XXX hospital was resorting to shortcut methods in sterilizing and fumigating operating theaters. This was what the judgment. Well-equipped ophthalmic OT was not used by the hospital, and there were no autoclave records available in the register. The said doctor should have not selected the XXX hospital for conducting the surgeries on the complainants when he knew that there was no proper sterilization in the OT done by that hospital. So we know that nowadays many of the hospitals, they allow us to do the surgeries, the freelancing kind of things. But it has to be proper, because even though it is not your mistake, you are liable for that. Whenever we do in any other hospital and we perform it, we are liable for that. Negligence. The treatment or the standard of the care was not as per the standard textbooks and or accepted professional practice, and patients suffered loss or injury. These are the only wordings which are going to work in the court. Greatest malpractice risk associated with endophthalmitis is the analysis of claims show that a high index of liability arises from a delay in diagnosis or treatment, including a delay in referring the patient to the VR, thinking that, okay, it will slow down, there is small inflammation, there is iritis, it will slow down, it will come down, let us start from steroid. So these are the problems which can lead the doctor to go to the legal court if the patient complains about it. Now, how to beat this? If the surgery was complicated, took a long time, yes, definitely sometimes extensive instrumentation might be required. The higher index of suspicion of endophthalmitis has to happen in that. And what we tell at our institute in Hubli is to do a SAVE, that is self-assessment of vision every day. Close one eyes and keep seeing at one distance. If they keep seeing it better and better, it is good. If it is worsening, then report back to the hospital immediately. You have to tell something to the patient, otherwise they will not be aware of it, especially when they come from the rural background. So educate your staff members who handle telephone calls about the risk and symptoms of endophthalmitis. Instruct them to schedule emergent appointments for that patient. Most of the times in the busy hospital, they try to take a routine appointment and they say the doctor is not available, come after 1 week. These are the most common problems which majority of the busy hospitals face. So err on the side of the patient safety when deciding to treat over the phone versus examining the patient. So document your decision-making process, obtain a thorough interval history and perform and document the clinical examination. In doubt, consult or refer the patients to the vitreoretinal specialist for further management. And of course, with proper documentation, make sure to document. So record all the findings, record and keep a copy with you. That is very, very important. And B-scan ultrasound if fundus cannot be seen at all is again very, very important point. And absolutely no telephonic treatment. The blind telephonic treatment is definitely sometimes a recipe for a disaster. Instead of telephonic, you can advise them to undergo the checkup at a nearest hospital wherever they are. So patients on treatment for endophthalmitis definitely should be evaluated. You all know that. And any case of pain, redness, decreased vision, then the patient has to be said to go to the nearest doctor. And measures to be taken to reduce the liability is proper informed consent. I think that there is no way we can get out with that. And emphasize the risk, especially if the patient has diabetes or on immunosuppression and complications including infection that can happen in the best of the hands. So have a prudent follow-up, diligently follow up all the patients who miss or cancel the appointment, especially the post-op patients, and contact them immediately if any pain or loss in the vision. Anterior segment fundus photography should be taken in the post-op if possible. Now coming to the interesting part is about the camps. The camp should not be used as an unsupervised training ground for postgraduates. There should be a pathologist who should examine urine, blood sugar and everything. A physician for the general medical checkup is a must, and all medicines consumables to be used of standard quality. Why I am saying this? Look at this. The original jurisdiction written petition, Supreme Court says that, okay, Lions Club Pottery Town in Khajuria arranged and opened an eye camp at Khurja after obtaining necessary permission from the CMO. In this connection, the club invited Dr. X and the team of doctors to do the surgical job. So I am deliberately not naming the doctors here, but these are all the well-proven one, and on the records I have taken this. The club published the propaganda literature with attractive slogans selling that get operated and go home. No restriction on food, no bed rest, no stitches to be removed. So sometimes we trivialize our own surgeries. Will any neurosurgeon say that, okay, we'll do a small burr hole, we'll remove the blood and you can go home? Will any cardiologist say that a small stent is required in your heart, we'll just put it and you can start walking? We ourselves are trivializing our own surgeries. We say that छोटा सा फेको है, get a phaco done and go and play golf. छोटा सा है, आपको ये नहीं, you can go to the... See, we trivialize because of increasing package rate. Sometimes some ophthalmologists, we try to trivialize our own thing. So 108 patients were operated, 84 developed endophthalmitis. The Supreme Court let down the guidelines after this incident. The fault was in the saline bottle procured by the government authorities, and the government was asked to pay for the compensation. So the doctor was... Fortunately, he was saved, because if you don't know, then you have to find out where is the culprit, because sometimes you are not in the faulty chain. Sometimes the drugs or usables might be faulty. So you have to find out what is the faulty and you have to prove it. Otherwise, the blame comes on the doctor. If it is any products which we procure, then it goes to the vendor, whoever gives you that. Dr. X presented. So this was another interesting. Cataract surgery was performed, 66 patients at a reputed hospital in South India. On that night, most of the patients experienced excruciating pain, and 61 of them lost their vision. 5 partially lost the vision. So the Chief Judicial Magistrate Court, which heard the case, convicted Dr. X of XXX Hospital, Chief Medical Officer, Chief Administrative Officer under Section 338 for culpable negligence and endangering the personal liberty of the patients and voluntarily hurting them. So the court also ordered the payment of a compensation to all the victims ranging up to 5 lakhs. And since the victims have already been paid, so they come under the compensation was fixed based on the Workmen's Compensation Act. So I'll not go into the details of it. Just in 1 minute, I'll finish it off. Whenever the complaint is received against a doctor by a hospital, by the consumer forum or by the criminal court, nowadays, all the cases are being shifted to, most of the cases are being shifted to the consumer court. And IMA actually lost the case when they fought it that the medical service, it's not considered as a service. It's the noblest kind of profession what we are doing. And it should not be considered as a service and treated as a service like how you have the banking service, how you have these kind of services. But unfortunately, the IMA failed in that case, and the cases now can go to the consumer court, and from the consumer court, again, it takes a long legal battle. So now it is totally at the discretion of the court and not a hard and the fast guideline. So again, the death caused by the penalty, section 304A IPC can be used, but for our safety, act not intended to cause death done by the consent in the good faith for person's benefit come under section 88 of IPC. Act done in good faith for the benefit of person without consent in emergency cases, it is considered as section 92 of IPC. And lastly, I would like to say, it's not merely on the formulation of the theoretical standard, but really on the professional commitment with which these are implemented. So please document. An ounce of prevention is better than a pound of cure. Thank you very much for the patient listening.